So welcome to another edition of our feature presentations in the Global Pandemic Midwifery Wisdom e-conference. So reports are coming in all over the media about women being told by their physicians to stay home, to find a midwife, to find a birth center. They're being told that it's safer for them. In fact, one post that I read this morning, the exact words quoted in the post from a Georgia doctor were, "I highly recommend you don't schedule another appointment with me and that you find a birth center or a midwife." We're also seeing several countries that have made broad and sweeping statements about the value and the importance of midwifery care at this time for normal, healthy women. And several countries have even embarked on projects to open emergency birth centers, emergency birth facilities. Notably, these countries also have socialized medicine, so they have the wherewithal and the resources and the capacity to do that. But nevertheless, if several national governments agree on a course of action, the rest of us should probably pay attention. I've been talking to midwives all over the globe for the last couple weeks and recording those conversations. You can actually watch them on my YouTube channel. Helene in the Netherlands said that her local hospital has taken over the neighboring birth center, the neighboring hotel to turn into a birth center. Likewise, Alice in the UK said that that's happening in Brighton and other places in England. And then here's a really fascinating statement out of Canada that came out this morning. It's a statement from the Canadian Association of Midwives and the National Aboriginal Council of Midwives. And it talks about the essential support, PPE, and rapid access to testing and that sort of thing. It talks about having a full and expanded scope of care and reduction in the challenges to get licensed in different locations and different hospitals so that they can meet the need more critically. But it also has a statement called primary care provision in the community. As hospitals see a surge in COVID-19 in the coming weeks and months, midwives can play an important role in reducing the number of patients entering and overburdening these facilities. Midwives are experts in supporting people and birth in out-of-hospital settings, such as homes and in birth centers, and can provide insight into the health systems during the pandemic. We recommend maintaining home birth as it continues to be a safe option to give birth for many clients, utilizing birth centers as key birthing locations for healthy people, and using them to full capacity during the crisis, and establishing temporary birth centers and sites that are intended for the care of healthy people out of hospitals. So that to me is very, very important information. And it's very, very reproducible. This should be happening in all countries, and it should have been happening for the last 100 years, but that's a different podcast. And so what we're here to talk about today, I've gathered a whole group of stakeholders, experts, interested folks who want to solve this problem and actually are starting to be on the path to solve this problem in the United States. It might be significantly harder in the US. We have a lot more challenges with not having an integrated healthcare system or response system. And yet, at the same time, we also have a nation of imaginative, inventive entrepreneurs who are used to making things up as they go along. So I have faith in the midwives and birthpreneurs of our nation to solve this problem. Let's start with introductions. My name is Augustine Colebrook. I've been a midwife for more than 20 years. My niche, my focus tends to be in establishing and sorting out the details around birth business. So I run the Birth Business Club, and it's a membership group of folks who are streamlining and creating success in their businesses. And I also run these daily calls in order to connect the profession. And I've invited several midwives to join us today, and stakeholders, interested folks. And so let's start with Cheryl. Can I call on you?
Yeah, sure.
Yeah. Will you give us an intro?
Sure. I'm Cheryl. I'm from Kansas City. I began practicing in 2006 before it was even legal in Missouri. It was a Class C felony when I began. I trained with some CNMs and was one of the first legal CPMs working here. I've done about 1,000 births. I began back in the day, I was an EMT before I made my transition into being a midwife. I specialize in rural births, so I'm used to doing births where we really better get a baby out because it's going to be a long time before we get to a hospital. We have big deserts of hospitals here where there will be 5 counties where there is no OB. All the way from the Iowa state line for like an hour and a half, we have no OB. So that's my specialty. And then a couple years ago, I went to a conference on becoming a MEAC accredited apprenticeship program. I have a passion for the PET process. And so I started working towards that, and along the way learned about the disparities in the ability for Black midwives to get training. So I started only training Black midwives until we have a Black midwife here, who will be Kim, who will be able to sign paperwork for other women that are like her. And this last year,
and she's on the call too, so that's so exciting. Thank you.
She's amazing. And
yes,
last year, I opened what will be a school and have been training doulas, phase 1 students, to go with the phase 2 classes I've been hosting for 5 years now. And my long-term goal is to have a MEAC accredited PET process.
that's exceptional. Thank you so much for your intro. Let's move to Kim now. Kimberly Lartey is also in your community and a student of yours.
Hi everyone, I'm Kimberly Lartey. My journey to becoming a student midwife, future midwife, is actually kind of a winding path of personal experience and professional experience. I have a bachelor's degree in sociology with an emphasis in Black studies and Latino studies. And so my career paths have always been about serving the community, serving communities of color. I have a culturally mixed family. And so we appreciate the value that bringing culture into everyday experiences and exchanging culture brings to our lives. And so everything I do comes from that perspective of honoring culture, whether it's mine or someone else's, and finding the common ground where we can respect the differences that we all have. We can acknowledge them and then respect them. And so after I got my bachelor's degree, I decided to study law because I felt like that was a pretty profound way of serving both communities, the Black community and the Latino community. However, during the course of law school, I actually became pregnant and with my 3rd child by that time, but I was connected with local doulas and the natural parenting world here in Kansas City. And it kind of opened my eyes to the world of birth work. And I knew immediately that that's what was for me. And so since then I have been a doula, and I'm now a phase 3 PEPS midwifery student, learning with Cheryl Gates of Casey Home Birth in Kansas City.
It's so exceptional.
I expect to be certified by the end of the year, hopefully sooner if NARM will continue scheduling the exams.
Right.
But I plan on specializing in serving the most vulnerable populations. I'm interested in communities of color. I'm interested in the lowest income populations, homeless people, people in shelters. I'm actually interested in moving into the prison population also. So I have a differing view on midwifery and its role in our communities. So that's me.
And it's such an important view. I feel like Sarah, who's on the call too, we want to connect you with one of our classmates who has also pioneered midwives working in the prison system in Washington State. So remind me, we'll make that connection. So thank you for being here, and thank you for your wisdom. I'm really excited to hear from you today. Sarah, let's go to you because I saw that you're here. Sarah and I have done so many Zoom calls together. Because we got to do our master's degree together at Bastyr University, and we both have masters in arts in maternal child health systems. So sorting out how the system responds to this crisis is definitely both in our wheelhouse. Sarah, will you give us an intro?
I'm a servant.
Yeah.
I'm Sarah, and I'm a servant. The way I've served sounds like titles that I don't like, but I'm the president of our state midwifery organization, Midwives Society of Oklahoma, also our NACPM chapter. Recently, I was appointed as the MANA Director of Organizational Development, And so that's how I'm serving my community. I've been a midwife for 13 years on February 14th. That my first catch was February 14th, so it's easy to remember. I own a birth center here in Tulsa, relatively high-ish volume. So what else do you want to know, Augustine?
And probably growing, right? Are you getting more calls?
We are. Yeah, we are. And we have more midwives, so that's lucky.
Yeah. Yeah, it's
We
pretty
just
exciting.
graduated 2.
Ooh, congrats.
Yeah, thanks.
One of the other things that I'm aware of that you have in your resume is that you also were a part of drafting your state's emergency preparedness response. Will you say that in the way it's supposed to sound?
Yeah, so it's the MSO, Emergency Childbirth Management Plan outline. And it's basically just a planning outline that gives us a direction if we need to pop up community birth facilities for larger volumes. I have a birth center, but this would be more beds and more like a single midwife managing multiple births.
Yeah. Okay. Well, we'll be excited to hear from you. Thanks for being on the call today.
Yeah, thanks for having me.
Let's move up to Emily now. Emily, welcome on the call. You're at our alma mater here, so give us your intro.
Hi, yeah, my name's Emily Jones. I use she, her pronouns. I have a Bachelor of Science in Anthropology from the University of California, Davis. I'm currently a 3rd year midwifery student at Bastyr University in the Masters of Science in Midwifery program. So my final year, my expected graduation is June of this year. And I am doing my master's thesis on the integration of community midwifery into Washington State disaster and emergency preparedness. So along those lines, I'm currently co-leading the Washington State Midwifery COVID-19 Response Coalition that's formed. It formed a couple weeks ago, and it's a group of midwives we're all kind of trying to plan what to do, put out documents, protocols, plans. So I'm involved with that. I'm also the operations director of an ad hoc committee that was put together through the Midwives Association of Washington State for mitigating the impact of COVID-19 on the low-risk perinatal population. So that's kind of what I'm doing.
So exciting. I have a question before we move on really quickly. You started working on this at least a year ago, right?
Yeah.
So you just happened to know?
Yeah.
How did you know this was the right research topic?
I wish I could have known.
Yeah.
No, yeah, I mean, the project I'm focusing on is general disasters and emergencies, so not specific to pandemics, but of course, a pandemic is a type of disaster. Yeah, I mean, I had no idea that this would happen at this point, right as I'm finishing up my program. So I experienced a lot of basically being ignored by hospitals when I tried to approach them over the past 2 years during my thesis, trying to, get in communication with them about their emergency preparedness protocols and plans, and to get community midwives integrated into their surge capacity plans in the event that, patient influx, things of that sort. But I was essentially ignored for most of that time, which, it would have been great to have this conversation a year ago with many of the hospitals in the area. But, I think now we're in a situation here where we're reacting to this, where maybe it could have been a proactive kind of plan. So it's
well,
great.
I think that's at the national level too, right?
Yeah. Yep, definitely. So yeah, we're working with what we got, and I'm happy to be part of it, and I'm really proud of all the midwives and birth workers in Washington State right now, and nationally and globally, how we're stepping up to this pandemic. And
that's exceptional. Well, thanks for being a part of today's conversation. I know you're really busy. It's great that you were able to take the time. Thank you so much. We're going to move now to our last panelist, Kyra. Am I saying it right? Can you correct me if I'm not?
Yes, it's Kyra.
Okay,
So-
thanks. Hi, Kyra. Welcome. Will you give us your intro?
Yeah, sure. So my name is Midwife Kyra. I am a practicing midwife, a licensed midwife and certified professional midwife in Louisiana, where I wish I could say we were as organized as Emily, but sadly we only have about 9 to 11 practicing midwives in the state. And as you guys probably already know, we have some of the worst birth outcomes in the country. And so I'm definitely going against the grain over here. I'm also an entrepreneur in spirit. I started a group of doula collectives about 7 to 10 years ago, where we currently have about 11 practicing doulas and placental encapsulators. We also teach childbirth education. I have an active YouTube channel called Cajun Stork, where I get down on a mama's level and really try to educate them about the midwives model of care and kind of give them tips on how they can bring our model of care into their hospital births and have better birth outcomes. But more importantly, the reason why I got here probably, Augustine, is because I run one of 3 freestanding birth centers in Louisiana, here in Lafayette in my city, and I'm in the process of opening a second one on the North Shore, north of New Orleans in Louisiana, where COVID is rampant right now. And I wouldn't necessarily say we're opening an emergency birth center clinic, because this was an idea that we were sort of in the process, but we've definitely fast forwarded in the last few weeks and hoping to open sometime in the next 2 weeks instead of month to 2 months. So it's been kind of crazy over here.
I bet it has, for multiple reasons. Well, we're really excited to hear your on-the-ground experience of getting a birth center open during this time frame. So thank you for joining the call. We'll be really excited to hear from you.
Thanks.
Well, so from a systems level perspective, which many of us are concerned with, how do we serve the most vulnerable population? How do we keep normal low-risk people low risk? How to create more capacity? I'm wondering, and we're gonna just kind of bounce around, so just unmute yourself and start talking, we'll figure it out. But what I'd like to do is invite us to have a conversation about really first steps. And we're talking nationally, and maybe even in a global perspective. From a systems level project perspective, what do we need to pay attention to first when we think about solving this system-wide problem? And then what are some of the specific first steps that you have or envision providers in each community taking? So for instance, from a systems level perspective, one of the initial identified problems is that we don't have enough locations. We don't have enough providers. And then even more in a specific way, we don't have enough assistants to assist providers. We don't have enough equipment. So obviously it's a broad problem in the United States, because all of these problems existed before the pandemic. But speaking from that big picture awareness, not necessarily your specific community, what's the biggest problem and what's the first step? That's my initial question. Not an easy question, I know. So remember, unmute yourself when you have something to share.
Well, I can just share from my.
Yes, everyone, I love it.
Everyone at once.
Okay, Kyra, you go first.
Okay, well, I know that these ladies probably have a lot more on a systemic level, but in my area, one of the things that would be a lot easier for me to serve the population and try and relieve some of the hospitals would be insurance coverage. So as a birth center, we have insurance coverage. However, I practice out of network largely with birth centers. So last week I got on the phone with Blue Cross Blue Shield, and her statement was, well, we view hospitals synonymous with birth centers. And if a woman can push out her baby at a birth center, there's no reason she can't exercise her in-network privileges and deliver her baby at a hospital. So when I tried to explain to her the difference, and also how midwives are, as I used to say, the queens of low resource, how we can deliver most babies without the need of IV fluids and oxygen and all the things that they're really on a shortage right now, her comment to me was, well, until the hospitals are deliberately diverting women from coming up for birth, we're not going to get you guys approval. And this is a huge problem. And I can't help but see that this might just blow up in the near future, as particularly in the New Orleans area, they're being inundated with COVID.
Yep. If we don't build capacity before it's needed, there won't be any capacity. This is what Emily was discovering. So Emily, let's go to you. You were saying.
Yeah. Right. Yeah, so I mean, one of the things the coalition is working on right now in Washington State is this idea of a community midwifery collective. It's the idea that community midwives can come together and be a shared resource to be at these alternate care facilities. And an alternate care facility in a disaster setting is any sort of ad hoc location. It can be medical, but it can be non-medical as well, that patients are diverted to. So this is in the event that hospitals are either non-functional because of a disaster or at capacity or no longer have the space. Then they're going to be diverting patients to alternate care facilities, and then creating a community midwifery collective in that event to have maybe one midwife who is overseeing a few labors, but has an assistant with them, and then maybe at another site, there's some more midwives who are working together to manage multiple labors going on. This is kind of what we see happening in converting freestanding birth centers to these alternate care facilities in disaster settings, because we already have the clinical infrastructure, we already have the midwives there to take care of these low risk clients. So if freestanding birth centers were to get full, then we would be looking at these other field sites, such as repurposing hotels, like you were talking about, maybe using other clinical sites, but also non-clinical sites that could be used to care for these low-risk individuals. So like I said, that's in the event of diversion. But what we're seeing right now is that there's still an influx. It's
like a self-selecting diversion, right? Like the moms are choosing, right? Okay, keep going. Sorry.
No, yeah, I mean, that's exactly what's going on right now. We're seeing community midwives experiencing a huge influx in clients right now. And so we're still having to think about, before we get to that hospital diversion state, what are we doing? One of the things that we're trying to do is get access to supplies for midwives. So I started working with healthcare coalitions in submitting resource request forms, which, there's healthcare coalitions leads. There's 3 of them in Washington State. Every state has a different number, and, it's different in each state, but in Washington State, there's 3 leads, and we have been collecting information from community midwives across the state. How many clients do you think you're gonna get in the next 6 months? Like, what is your capacity? What do you personally, as a practice, think that you could take on? And what do you need? What do you need help with? Is it supplies? Is it PPE? What do you need? And how can we get that to you? So we're reaching out to these healthcare coalitions, and we're doing weekly submissions. And just today, we had one of the healthcare coalition leads in Eastern Washington coordinate with a local hospital to donate some supplies to a birth center in Eastern Washington. So they got some more gloves and a few other supplies that they were in short supply of. And so it's a combination of things, but I think a major thing right now that a lot of midwives, at least in Washington State, are worried about is, how do we get supplies? And what do we do when we get this influx of clients that we want to care for, but may not have the capacity to? So that's kind of where I'm at with it right now.
I love that. Thanks for that. And Sarah, you had some things to chime in with too about the systems level perspective.
Well, I was just going to share what we wrote for our outline, and it is basically, I mean, this emergency response has been done, right? So like in Oklahoma, we have the Oklahoma Medical Reserve Corps. FEMA has a lot of outlines, and pretty much everything that Emily said, I'm really happy, is what's written down in our outline. Basically, identify birthing location. Community is super important, because as Emily said, I'm just thrilled to death that Emily said all of the things that are on this outline, because
3 years of research shows that you were right. She did all this research.
I'm brilliant. I'm brilliantly happy about it. Yeah. So, But what I have is first assign a leader, right? And then identify your available providers. I think it's important. I did my capstone on sustainable practice models, and that has a lot to do with grouping. And so I think every midwife should have a group either in mind or actually established. But in this, you would need a group of certified CPM, CNM, LM, internationally credentialed. I think it's super important systemically to make sure, because we don't know necessarily the people who are going to be on our teams or who are going to be coming to fulfill a need, that we have outside certification requirements for those providers, retired MDs, DOs, retired midwives.
Yeah. Well, so it seems like, I mean, this is just a complete commentary, not a forward going motion, but like one of the things that we're all doing is acknowledging what's changing. And it seems to me that this pandemic, if nothing else, has highlighted the demise of many of our previous processes. And one of them is this isolated, independent, avant-garde, like, rogue private cowboy midwife thing that's been happening across the United States in community-based birth. It seems like that is dying. Like there's no way to be a rogue cowboy midwife.
It's not sustainable.
It's not sustainable. We've known it's not sustainable, but now actually we can't keep going in that model. Right. We must learn how to work together. So I'm hearing from Emily and Sarah this really important point that I think is not being talked about. And that's the point to organize and leaderize. Like, I don't think that's a verb, but you know what I'm saying? Like find the point person in each community, locate a facility, and actually start to plan to gather supplies and work together. Any comments on that?
Yes.
Yeah.
So in our community, like we've been working together for 5 years to come up with like, what does the definition of low risk look like? We worked as a collective and then transfer programs with all the hospitals. I have a birth supply company. And so we have supplies. We have a thick group of midwives. Most of us have partnering, and we've got plans like I'm going to get sick first. And then when I get sick, my best friend is taking over my practice and her practice while I recover. And then she's going to get sick because she was practicing, and then I'll take back. Like we've got all of this down, but where we're at, we don't have the ability to open a birth center. Because the state of Missouri's birth center regulations were enacted before CPMs were legal. And so we're nowhere in it. The few CPMs running birth centers, there's a 51% rule, which they just prosecuted one of them over it. And she did win, but that's an incredible price to pay in your life to be prosecuted. The one free center
tell us a little background. I want to understand, what is 51% and what does that mean?
If you did 51% of your births as home births and 49% of them in your birth center, they would not call it a birth center. It would simply be an unlicensed building where people's babies happen to fall out.
That is the strangest rule I've ever heard.
No Medicaid reimbursement. We can't get licensure. And so, and one person, she spent over $300,000 building the building to the state of Missouri's requirements. She still doesn't have a license, and she can't work in her own birth center because she's not a CNM, and the CNMs have to have collaborative practice agreements that they can't get.
So you've just perfectly named one of the real crisis points in the United States, which is this 5 different provider types, 50 Correct. Or actually I think 39 different licenses, because they don't even all offer licensing. Right. And this system that has pit provider types against each other. Obviously, we're not going to solve that problem in this call. But I think I want to differentiate like 2 conversations about this. Number one is, as it is right now, and potentially for the next few weeks, or if we successfully flatten the curve and we never get to crisis point, then the laws as they stand and the provider type, differentiation as it stands will always be the impediment. That's what needs to be solved in the United States healthcare maternity care system. But then the other conversation in this topic is if we actually have capacity overload in this existing system. And I kind of want to go down that path in our conversation today. And to the listeners, it is theoretical at this point. And I don't think any one of us is recommending that people break laws and what have you, but it is a real and potential reality that the United States healthcare system, as it currently stands, will be overwhelmed by the number of sick patients. And as we saw in Italy and Spain, where they took over maternity wards to turn them into COVID wards, and pregnant laboring people who showed up at the hospital were literally turned away, that is a real potential in the United States. And so what I want to do with our conversation today is take that path less traveled and brainstorm and discuss and ruminate over what we would do then. So anyone want to take it away there with that happy note? But seriously, I think it's really possible. Go ahead.
If we're thinking that, if we're able to think that far out of the box, I would like to envision, what about someone offering to use their property to host several, like an RV camp, a temporary RV camp, where people drive up and use an RV and have a baby. And there's maybe a circle of them, and there's 10 families birthing individually. But the midwives in the area, 1 or 2 or 3 or however many are needed, are there serving them. If we're moving that far out of the mainstream, I think that there are options out there. I think it's going to take developing new relationships. It's going to take talking to people who don't have those titles and who don't fill those roles, but who are willing to do something to help. If in our area, the CPMs are full because they have to go to so many different locations to have babies to do home births, finding ways for them to have out of hospital births in a more closely situated area.
Yeah, absolutely. I love that. So let's stay on this path, because I think you've really hit on the brilliance here. In our cowboy Wild West American healthcare system, envisioning this potential move into a disaster unparalleled, where the healthcare system is overwhelmed and the midwives of the country are looking to solve the need of low-risk healthy women with the limited numbers that we are, because we can't do all home births. Let's brainstorm potential connections. Like, imagine your community and think of like what Kimberly was saying, like a mobile home park where there's probably a bunch of empty mobile homes right now. There's like a bunch of empty motels. Let's brainstorm people or places. Sarah, I know you had done some of this with your preparation. Who could a leader in a community try to reach out to find a facility?
I think we've seen worldwide that hotels, they have a number of beds, they have private bathrooms, they're empty right now. That can be a hard sell, but it's a way less hard sell if women are getting turned away from the hospital.
Yeah, I was thinking, go ahead.
They've done that here for recovering COVID patients. They've paid a local hotel. I think it's in Kansas City, but people who are recovering from it, they're sending them, homeless people who are recovering from COVID-19 are going into this hotel for their recovery period. So it's already being done here under certain circumstances. I don't think the conversation has been had yet about using that for low risk birthing people.
Well, I was going to suggest, I think every town in America has a motel that's privately owned. Not a chain, which would be bureaucracy and politics and liability and insurance, but actually a locally owned small motel hotel. And I bet with enough research, you could find the owner. And I'm thinking that we need to have on-site washer and dryers. And you pitch the idea to the owner, the local person that you can talk to, the owner of the motel, that you would like to figure out how to get his facility used and paid for. Right now he's sitting empty. You would like to rehire his house cleaning staff to keep the process running. And you would like to convert his facility. And I bet there's going to be some takers, because right now they are sitting empty with no money. And, you know, hotels run practically in the red all the time anyway. They have to be booked more than 50% to run in the black. And so we're going to see massive, massive losses of those businesses if this goes on for any significant amount of time. And so I can't imagine a private personal entrepreneur turning down some way to make money when there's no other way. But I think they have to have washer and dryer services on site. And I think utilizing the cleaning staff that was already employed with that organization is going to be a big key to success of that potential temporary facility. Anyone else have?
In Missouri,
ideas?
we'd have to go outside of that also. We'd have to go farther than that.
Okay, tell me more.
Cheryl knows a little more than I do about that.
So in Missouri, in the past, I've allowed people from illegal states to come to my home and have babies. And in each home, if more than 2 babies are born that are not from the renter or owner, it's now a birth center. And they will come in and say that you need to meet.
Yeah, but we're talking about when we're past, there's no government agencies to pay attention anymore. You're just solving the need, you know? So what I'm saying is build the relationship now in case that happens. I mean, again, I'm not recommending that lots of people break the law, but I am saying that the laws are moot when the existing system can no longer provide the service. So the hospitals, your local hospitals have all taken over maternity wards for COVID patients. Pregnant women are literally banging on the door and not allowed in. What do? I think no government agency is going to have the staff, let alone the wherewithal, to police people who are serving the public good. You know what I'm saying?
We've seen that. We've seen in other states and nationwide that governors are signing decrees saying,
help,
take care.
Please help us.
Just help.
So
us.
in Washington or in New York State, Governor Cuomo signed an order saying licensed midwives from any other state are welcome to come in and work in New York. That's the kind of about face that's going to happen if our systems become overwhelmed. And so, like we made the point in the very beginning, if we don't build capacity now, it will not be there when we need it. And the societal breakdown will be at such a point you may not be able to find the people that you need to make the solutions and build the problems, build the solutions to the problems. So my idea was to connect with the local entrepreneur, owner of a local motel, hotel, and talk through this emergency plan with them, get them on board before you need it. Kyra?
Well, Augustine, something else to think about too is, you know, y'all are coming from areas where there's a lot of midwives. In my area, in my city in particular, I have 4 midwives, but like I said, there's only 9 to 11 in the state. Now, we have certified nurse midwives who practice in Baton Rouge, and I think also in New Orleans, if I'm not mistaken, but these are women who all the ones I've spoken to, only one have experience with out-of-hospital birth. And as you guys probably already know, this is a completely different mindset.
Completely different.
How do you help a woman give birth without IV fluids? Like, that's something that's a no-brainer for the rest of us, but for them, they're really struggling to put together the pieces. And so we have to really take that into account. A, who's going to deliver these babies, but B, who's going to assist these women to deliver babies, you know? And that's really been a struggle for me as I'm trying to staff. You know, I have LMs, CPMs in my birth center, but as I'm trying to talk to CNMs to see how they can help us out, because our governor also removed the collaborative agreement in Louisiana for CNMs.
Oh, that's exciting. I didn't hear that. That's very exciting.
But
Good.
The problem is these CNMs, it appears as that they don't know how to practice independently. They're used to their collaborative agreement. And so now they're like, well, we don't know what our scope is. So
you know, this is totally, this is a major problem. This is actually what I wrote my thesis, my capstone on, was creating a community-based birth residency program, because provider types like CNMs and OBs and NDs, they don't get any actual apprenticeship in a community-based birth. And community-based birth is radically different than hospital-based birth. And you don't need more hospital training to be good in the community. You need more community training. So you are absolutely right. This is what I did like years of research on, but it's a real crisis point because hospital-based providers might be very skilled at knowing pharmacology or delivering babies, but they're used to the button that you can push to call phlebotomy and pharmacology and nursing and janitorial and like all the other roles that community-based birth providers run. So it is a real problem. How are we going to solve that problem? Like, we're all entrepreneurs on this call. What can we do? Emily?
Yeah, I mean, one of the things that we've been thinking about over here is training, is training nurses to be birth assistants for us in the community setting. So there is a birth assistant training course that's done over here. It's online and it's been, reduced price right now. And we're hoping that people maybe who are trained in the hospital setting can take that and can learn, because it's a birth assistant class that's focused on community birth, right? It's specific to that. So it's focused on that. So maybe hospital-based providers, even nurse midwives, can take it and understand maybe a little bit more about what it's like to be a provider or an assistant even in the community birth setting. So we're hoping to start integrating some hospital-based providers into the community birth center by doing these online trainings that obviously you don't have to do in person because we want to limit that. So it can be done online. And then you are starting to recruit people to assist you in the out-of-hospital setting. And so I think that's one way to approach it.
That's awesome. There's a community-based birth assistant training that's just launching in Alaska called the Pacific Birth Institute. I'm doing some consulting on their course content, and I bet there's more out there. So we could create a resource list for and identify potential community supporters, community assistants. What else? Kyra, were you going to say something?
I was just wondering, like, how many nurses are signing up for these classes before it's too late and now we have to throw them into the field? Are y'all getting a lot of people registering?
There's been an increased number of people registering, it sounds like, but I don't know if they're necessarily nurses from the hospital. It could also just be community members who want to take this course. So what I think it is being able to do an outreach to hospital providers. And I know that's not necessarily feasible in every setting, but I'm thinking, sending out a call to hospital-based providers saying there's this course and we need your help and would you be willing to do this? Because I know that nurses are needed too in their setting right now. But it's a matter of, I think, mostly outreach and communication, which is not always possible for every region, right? So, I mean, here in Washington State, I think we're pretty fortunate that we have, on the whole, a pretty good relationship with a lot of the hospitals, I mean, it's amicable at times. And so doing that may be more feasible, but maybe not everywhere. And so it could also be just an outreach to community members who maybe are doulas or who have been interested in being birth assistants and putting this call out to your community members. So maybe not even going to the hospital setting necessarily to find those providers, but reaching out to community members who are somehow involved in birth work and want to get this training.
Well, Emily, it's really interesting. I got a call this week from a friend in California who is a birth doula and also a chiropractor. And she's asking me to do a training to help chiropractors take on the birth assisting role, which I love because there is a lot of chiropractors in the United States. They all had to do extensive anatomy and physiology. Many of them even had obstetrics parts of their training. And by and large, they tend to be pretty supportive of community-based birth and midwives. So that, to me, we'll see what happens with that, because I would love to empower dedicated chiropractors to come support midwives around the nation. Wouldn't that be amazing? Your assistant would always be a chiropractor who has that ability to also adjust your clients. Wouldn't that change our lives? I don't know. Kimberly, I think we're getting a little feedback from your line. Were you about to say something?
I was at one point. I just started listening. Okay. Sorry.
Please go ahead. No.
I'm just, if I am putting myself in a creative space, but still within my current context, I think that there needs to be a lot of education about the difference between home birth and hospital birth right now. I think that's a really big factor that's going to impact the outcomes that you all are talking about. When the hospitals shut their doors and say that we can't take you anymore, you have these terrified, traumatized women who are trying to do something that needs relaxation and calm and safety. And so if they're not prepared mentally for what a home birth or out of hospital birth might look like, I think we would all be kind of setting ourselves up for a lot of chaos. And so within any plan for an emergency transition, we need to have that background work being done already, educating the community. What is the difference? How does out of hospital birth feel different, look different, smell different? What's available, what's not available? What are your options? I mean, we've had people calling, we were on a call with the KC Midwives last week, and they're fielding calls about, can you get an epidural at home?
So much misinformation. Yeah, it's crazy.
Right. And so any disaster plan needs to incorporate how to educate the community on the realities of what it might look like for them too. That's what I was thinking.
Yeah. No, on that note, during my thesis, writing it so far, that's one of the things that I created was this kind of prototype script for hospital providers to talk to patients who are being diverted to out of hospital settings. And then you want to think about also creating that for community midwives to have when clients are coming into care. And it's primarily about transparency and having a consult, but specific to maybe this pandemic, that informs about what the reality is and what is available. And so having it on both sides, so both from the hospital provider perspective and from the community midwife perspective, and being able to talk to clients in all honesty about what that looks like. Because you're right, Kimberly, in the sense that we know that outcomes are worse when people are not informed of their choices as why they're doing what they're doing, or if they feel uncomfortable or not safe. And so that is a huge part of disaster settings. And I actually think community midwives are so important because we're so good at doing that, right? Community midwives, we're good at doing informed choice. We're good at talking to people about what this looks like and giving all the options and doing these kind of thorough conversations. And so I think we're actually poised in a way as a profession to be very valuable in that sense too, for the mental health of people, for the way that this impacts long-term, right? For people who went from planned hospital birth to community birth, being able to hold people and talk to them through that whole transition. I think we are already pretty good at that, or many of us could be good at that, So I agree. And I think that's important to think about for sure.
I had another question also. So one of the things that we're seeing and that I've seen in these nationwide international conversations about midwifery and how we can use our skills and our knowledge to help during these pandemics. But there is a vast difference between midwives in states that have either supportive regulation or decriminalization at the least of midwifery. And then there are communities around the country who suffer under either the criminalization of midwifery or not being able to be licensed and all of this. And so even in this conversation we're having here, we're seeing the difference between, Washington State, where midwifery is much more available and supported, whereas in Missouri, it's a very fine line. And what I know here is that we kind of operate under a cloud of impending doom if we do too much, if we cross the line. And so in order to build capacity here, there needs to be that type of lessening that fear that midwives have here of being prosecuted for trying to help. So I'm interested in hearing also from others who are more able to do things. Would you be interested in writing a letter of support or some type of protocol that the midwives here can use? What if our governor doesn't give us permission to do these things? And we say, you know what, but we're going to do it anyway, because we know that it's for the common good. We have the ability, we have the capacity, We just don't have the legal ability. So would the national community of midwives who are able to do that support us in that moment? That might allow us to think more outside the box and to implement more of these plans and to feel like we can do more and help more. If at least we know the broader community of midwives would support us at the end of the day.
That's like a question for Manna. I mean, certainly, Sarah, I know that you don't want to be tasked with speaking for Manna in any way, but as the new Manna Director of Organizational Development, can I ask you to talk about what could happen? Could Manna send a letter to those 14, 17 states that still don't have licensure?
Manna has actually already done that.
Okay, great.
Go to the Manna website, you'll see that there are at least 2 statements advocating for immediate licensure, lifting of restrictions.
That's exciting.
Are doing, our bill is it's gone through the Senate. It was in the House when everything hit and they fled.
Yeah, because you're in a non-licensed state, right?
That's right. We're legal but unregulated.
Yeah.
And have been since statehood, legal and unregulated. And we were happy with that until somebody got prosecuted with felony charges. None of us want that. So we have a bill in before the legislature right now. But even our governor lifted restrictions on licensing, and so it could be interpreted that we have the ability to. I'm licensed in Texas, so.
One of the questions I had was there was a statement about being able to cross state lines in practice without having to do anything different. And it occurred to me that like somebody should cross state lines into Nebraska, because Nebraska families are going to be completely desolate if they get turned away.
Completely. Yeah, there's like no midwives in Nebraska. Yeah.
Yeah. And some of us would be willing to go there and form and do this, but I just wouldn't even know where to start.
I know, it's a massive problem, and actually not akin to the problem that Louisiana is facing, even though it's a legal state. 9 midwives for a state of, I mean, how many? What's your population of your state?
I have no idea.
A lot. Let's just say a lot of people.
Sure. Yeah.
A lot of people live there, and that's not enough midwives. And so I think, I mean, the other very real possibility is that we won't be able to meet, even in any significant way, the numbers of people that are coming out of a system that collapses. And so I guess I want to take another veer into, el mundo malo, the bad reality right now, and think about two questions. One, how am I going to say this? So one part of this question is the very real skill of risk assessment and knowing that we actually cannot and should not take everyone who comes to us. And then the like el mundo malo, the bad reality kind of thought process where it's like, there's nobody else to take them. And I wondered if you guys have comments or thoughts on either of those.
It's a fine line, it's a fine line between the boundary of, I know I can do one more. I know I can be on call for one more, and running out of supplies for the ones that you've committed to who started in their pregnancy with you from day one. We've been having a really hard time securing supplies for our birth centers out here. We don't have organizations to do it for us. We've been locked out of our Amazon accounts to get even just cleaning supplies for our facility. And like I was telling my husband, we were ordering stuff this week. If I can't get bleach, I can't attend births, even if I have Pitocin, because I have to be able to clean and disinfect my facility from them infecting one another.
Why can't you order on Amazon?
So Amazon has locked out all like medical related supplies and cleaning supplies that would be used and diverted to hospitals. So you have to have an accredited facility as of, I think, last Tuesday to order something like that on Amazon. So we've had to change all of our cleaning stuff to bleach, which is hard to get to. And like I said, you know.
Can I give you an idea of that? Because one of my passions is like securing my borders. Like, what am I doing to protect me and my own? And one of the moms from a very long ago birth was there the other night as a support person. And we were talking about the bleach shortage and how, like, I know how to make my own disinfectant, but what do I do when I run out of bleach? What about I've only got 196 bleach tabs, then what? And her husband works at a water treatment plant. He does water treatment and he was like, I can teach you how to make bleach. I was like, mind blown. Can you teach me how to make clavicide? So that's what I sent her today.
Oh my God.
Look up what's in clavicide and teach us how to make clavicide. So
oh my God, the job description for midwifery just got extreme.
Yeah. Well, you got to be thinking this way, that if we go there, what is the very minimum that we need? We need some cloth checks pads, maybe newspapers. They're using newspapers in the lowest resource countries. And I need some metal instruments that can be re-sterilized. I can do without cord clamps. I can do without the fancy ties. I don't want to do without Pitocin, but I believe in my hands. I know how to do my manual compression and it works. And so there are things that we can do without and there are things we can't. I've debated on the bleach one. What would you do if she's sitting there, she's having a baby, you have no gloves? That was the one that freaked me out. When I saw they were rationing gloves, I was like, I'm going to be sticking my hands in someone's goo. And I had to come to terms with I was probably still going to do it. They've all had testing. I know they don't have hepatitis. I know they don't have HIV. Okay, it's gross, but what am I going to do? Am I going to walk away? And this is back in the day when we had to decide on whether we would practice when it was illegal. I had to look at myself and say, I answer to what I think is ethical. And that means that if it's ethical to take care of her, I will do it. And that would be where we would end up. In the very worst case scenario, you would be looking at women and saying, you have no help to be had. I'm probably your best option. It might not turn out okay. Yeah. And that's what we do when we go to other countries. Midwives just love to go over to other countries and serve where there is no help to be had. So we really have to challenge ourselves on, if we can do it in that situation, can we do it for the people here in our own community?
Oh God, it's hard to even conceptualize, but it's yeah.
It makes me sick to my stomach to think about having to push those boundaries. That these were the boundaries that we learned because they were safe. And so I've been really, really obedient to those. Like, I don't go outside them. And so now what? Like, if we have to go outside them, then we're all going to be uncomfortable. Like, even just the PPE at births feels like you're sitting. I had one mom who was terrified. You could see that all of this was terrifying her. And I'm in this debate of my safety versus hers. And worst case is not pretty. But we probably won't get there. That's honest.
Yeah, that's honest.
Our hospitals here are saying we're not going to go over our capacity, even on ventilators.
There's that good report that's been passed around that you can go and look at your state by averages and stuff, and a vast majority of, especially the center part of the country, seems like, for whatever reason, their people compared to their facilities are well matched, even in pandemic.
Hospitals in our communities. That's an interesting.
You have what?
As managed healthcare has come through and corporatized healthcare, they've bought the smaller hospitals and closed them. So, like, one of our hospitals has another branch of another hospital sitting completely empty right next to it. And they're using our normal transfer facility. This is the most friendly hospital we have, with wonderful hospitalists, birth tubs, birth balls, like all of the things. That's going to be the COVID hospital for that company. And so they have an empty one sitting half a mile away. I'm like, why are we not just making the empty hospital into a birth center? Put all the healthy people in the empty hospital.
Wow.
Same thing just happened here too.
Wow.
And all the
so the hospital desert reality, where 50% of the U.S. counties have no obstetrical services, doesn't mean they don't have facilities. The facilities just aren't staffed.
or they're
Hmm.
closed. That's what they're
Mhm.
doing, is closing them, or they come into the rural areas and they buy these tiny hospitals that are really doing a good job of serving that culture, and they replace it with this big corporate hospital that's very expensive and end up closing things, and then, oh, we don't do OB anymore, it's not profitable.
Yeah, no, we've seen that. The statistics now are that 50% of US counties have no obstetrical services. And you're obviously in one of those deserts, but it seems like maybe in apocalyptic kind of vision, there are still facilities. So
Right.
that'll be
I
interesting.
wonder, how would a midwife go about talking to the owner of the hospital, the empty one, and saying, if we get overrun, I know how to do this.
Your mayor.
Yeah.
Your mayor knows who owns that
Yeah,
hospital.
exactly.
Yeah.
Mayor in the town.
Okay.
Yeah,
I
that
get
happened in California. I think a mayor in California had basically said that hotels could be used as facilities.
Okay.
So going through that venue could work.
Yeah. Okay.
Mhm.
We're gonna do this.
This has been so amazing, you guys. I'm so honored to sit in this circle with these change makers and visionaries and entrepreneurs and you guys are incredible. Let's wrap up today's conversation with some takeaways. As you're sitting there thinking about sharing this conversation with a nation and potentially a world of midwives and people who care about birth work and the safety of maternity care, let's answer 2 questions. What do you need and what do you have to offer? And hope that helps share and communicate and connect with others around the country.
Did Emily want to go first? I see her unmuting herself. No. So interestingly, what I believe is that we have what we need. We have the knowledge. It's been maintained and passed down. They just have to give us the ability to use it. I believe in the unlimited wealth. Like when I said I need masks, 200 masks showed up at my house.
Beautiful.
And so I really believe that what's taken away our ability to take care of ourselves is bureaucracy and red tape. Like, that's what we need, is the ability to just do what we already know how to do.
Brilliant.
I'd like to circle back around and say what we need is respect. But right now, there are a lot of people who want to know how we do what we do. So somebody said, low resource queens, right? We can have a baby. We have hands. We like gloves. If there's a baby inside somebody, we can get it out. So, and right now there's a premium on that information. And if nothing else happens, go out into your community and offer to talk to people about how you do what you do. And maybe we'll get that understanding that we haven't had the opportunity to share so far.
Brilliant.
I would like to see an increase in the self-selecting diversion, as you said earlier. In my practice, I've seen an influx of women. None of them have said, I hadn't considered this. All of them said, I considered this, but dad wasn't supportive, but my doctor said this wasn't a good idea, whatever the case. If women would willingly choose to self-selectively divert themselves to midwives when they know that they're healthy and they're low risk, they know they want a natural birth, take out all the barriers and just make the leap, they're serving themselves and they're helping us to help them by giving us time to prepare for them and the women who won't do this for themselves until it's too late. So I really wish people would stop focusing on the sick and waiting till things get worse and really just make the leap now while they're thinking about it and ask the questions now while it's available.
Tyra, I love that. Friday, we're doing this panel conversation with a group of mothers who have just given birth within the last 4 days and have chosen home birth with midwives. So we're addressing this exact issue, how they made this decision and why they made this decision, and then a bit of their experience. So that is such a brilliant idea. I'm with you. Thank you.
I feel like I want to say, in Washington, we're creating a lot of policies and procedures and ideas about how to go about doing a midwifery collective in that event. And I think it's our responsibility to share that. So once we have that finalized and available, I'm hoping that we can distribute it to midwives across the country, so that, of course, it's not going to be, you can't replicate it exactly because it's a different region, a different area, a different culture, but being able to take that and rather than reinventing the wheel, you can use that concept and adapt it to your setting. So what does it look like in a different state? What does it look like for your community? So I think a lot of it is being able to come together on a larger level as midwives and share resources and be able to offer things when you've created them and do that kind of sharing and in support, like Kimberly was talking about, being able to support with letters or resources or documents, whatever it is. So I think that's what's needed also, and doing things like this, sharing information this way as well.
Yeah. Thank you for that, Emily. And thank you for what you have researched and shared with the world. It's going to change lives. Thank you.
So, I mean, from listening to you all talk, I think that we need to have different conversations with different stakeholders. You guys have got me thinking now about the different people I want to go talk to. I'm going to talk in my network about people who own land. I'm going to talk in my network about people who would be willing to have conversations about out-of-hospital birth before they need it. I'm going to try to get in contact with the mayor. These conversations need to happen immediately. And even if we don't reach peak capacity, even if we don't go over the cliff, those conversations will have, I think, a positive impact on midwifery moving forward. I think that we need to leverage the crisis that we're in and the attention that can be placed on out-of-hospital birth and what midwives have to offer in any setting. I think we need to have that conversation, leverage our position right now. We're kind of in the spotlight. They need us. We are needed. And
Yes.
we need people to understand that we're needed every day, not just in a crisis.
Well, okay.
That's right.
And systems development, because
Yes.
this pandemic is the first in 100 years, but it's not China's first in 100 years. And so what are we going to do when the next one comes? Developing the system now, even if we don't need it, might provide us what we need the next time that we outdo our resources.
Love that. Love that. Oh, I'm so inspired. Thank you to each of you. This has been exceptional. I can't wait to share this with the world, and let's stay in touch. If things change, if you find success or change in what you're doing, report back. We'll do another one. Thanks, everyone.